would be kind enough to introduce Dr. Brian Kroll on our Arthroscopy Academy behalf, please?
Yeah.
So, it gives me a great pleasure
Wait,
to.
wait.
Wait, sir. I'm putting live on YouTube.
As soon as this is live on YouTube, sir.
Yeah.
Just a minute.
1 minute. Just 1 minute. Is internet slow everywhere? Yeah, we are live on YouTube now. Okay. Dr. Antao, you can start the introduction.
It gives me a great pleasure to introduce Dr. Brian Cole, a very high-rated academician uh, in the Department of Orthopedics, known the world over. His work on cartilage. He's the chairman of Department of Surgery, Rashok Park Hospital, and he's in the Division of Sports Medicine, shoulder, elbow, and knee. And he is in charge of many sports teams. I think the Cubs and the, if I'm going wrong, Brian, please
Chicago
correct.
Bulls.
Okay. And if you have to look for his research and papers that he has published, it's very high-rated papers, very teaching papers, and all the time when you talk to Brian, there is something you get to know, get like taking a message home, and not only he is recognized the world over, but among his peers, he is considered one of the best, and no wonder he is the incoming president of the ANA. With this short introduction, I would like Dr. Brian Corder a very warm welcome and to start this presentation.
Yeah. So somebody known as Mr. iPad has logged in. iPad, can you start your video? Mr. iPad? Yeah, Brian, please. Yes.
Good morning. Okay, I just want to verify if one person could hold their hand up or indicate that you can hear me well. Okay, thank you. So it's a pleasure to be with you this evening. I'm broadcasting from our lake home in Indiana, outside of Chicago. And everyone in our family is healthy and safe. And I'm sure we're all kind of going through some very similar things in our personal and professional lives. And I wish all of you continued health. I was asked by the organizers to provide a session on rotator cuff, which I'm very happy to do. I wanted to start with this slide because this to me is the most important. I've been to India 2 times and visiting, and invited many times, and difficult scheduling sometimes because of sports coverage and so forth, but I have many fond memories. And in return for the wonderful treatment and by my hosts, we thought for our next annual meeting for the Arthroscopy Association of North America that we would include India as our guest nation. So I want each of you, if you would please, and you have an interest in being in Chicago in April of next year, April 22nd through 24th, to attend, and many of you will actually be asked to participate at the Arthroscopy Association of North America's annual meeting, and it's a banner year as it's our 35-year anniversary. Nick Verma, my partner at Rush, is the program chair. So he and I aim to be very inclusive and have an entire session dedicated to you as a visiting nation, in addition to hoping to share some of the wonderful things that we have in Chicago during that time of the year. Hopefully, God willing, things will be in a better place for all of us, and we'll be able to do some of this face-to-face and enjoy some of those benefits. The 3 lectures that I'm going to give will include a decision-making lecture, tips for success, and also talk about orthobiologics. And I'll try to, because sometimes I do tend to speak fast, I'm going to really stick to the main points for each of these to hopefully drive home a clean message.
Brian, time is no problem. You can take your time. We have plenty of time online. So let it be at our advantage.
Sure. Thank you. That's good for me. Usually I have 9 minutes to get a 50-minute message across. So other than maybe being interrupted by my dog or my children, I think we'll be good. Okay. With this, my disclosures are all listed on the American Academy of Orthopedic Surgeons website for all of my talks for full conflicts and disclosures. So this is a case I'll show, and you'll see it again, is sort of the beginning of the genesis of all of this. This is a 62-year-old male who fell onto his shoulder, and he's complaining of weakness and pain. You might argue that at presentation, he's pseudoparalytic. You get a sense that he's probably had a chronic rotator cuff tear, at least of the supra and the infraspinatus, with some grade 1, grade 2 boot to the 8 changes as seen in the outlet view of the MRI, and no visible osteoarthritis. And we may ask ourselves, how common is this? And while many talks include incidents and so forth, I think it's important to understand that by understanding the prevalence and the incidence of rotator cuff pathology, you get a very good clue as to how you treat it. And what's fascinating is that if we just take the population in the United States in 2010, the incidence is estimated to be in those over 60 to 65, somewhere 10 to 30%. So at that time, there were 57 million people. And that means that there were 5.7 million people in the United States with the rotator cuff tear. But yet we were only fixing about 270,000 rotator cuffs per year. That means less than 5% were actually being treated. And why is that such a critical number? That means that you and me are able to tolerate rotator cuff pathology to a high degree. And we don't learn about it until we actually obtain an MRI or after a patient has experienced an episode with pain. The other thing that's important is that patient satisfaction is really our number one outcome variable. We have a number of outcome assessment tools that evaluate subjective relief, functional return, and resolution of night pain and improvements in activities. But what we've learned about patient satisfaction is that it's strongly linked to the expectations of the patient. And currently in the United States, I will tell you that we have something called value-based care, where the outcomes that our patients achieve will actually affect physician reimbursement. So that's another important factor. So what do we know? What we do know about rotator cuff pathology is that pain is more likely in that nearly 6 million people who have rotator cuff tears, those who have larger tears where the biceps is involved, where the chronicity is greater due to with associated fatty infiltration. They tend to be somewhat older. They often present with scapulothoracic dysfunction, and that's important because that is one avenue to actually resolve their symptoms when they present with scapulothoracic dysfunction. The other thing that we've found is that pain cannot actually predict the progression of the tear. And we know roughly about 40% of tears will progress over 2 to 4 years. So using the argument when you assess and identify rotator cuff tear in an individual that, well, we must fix this because it might progress, is certainly a narrative that we have in our clinical setting, but not all tears progress. And it gives us lots of room to treat these conservatively, because as I've told you, we know that millions of people walk around with rotator cuff pathology, yet never seek treatment. So it was Voltaire who said that the art of medicine consists of amusing the patient while nature cures the disease. And that's an incredibly important statement as it relates to the natural history of symptoms and of rotator cuff pathology. Mostly what we do in this setting is provide reassurance for our patients and non-surgical care in a chronic setting. We know the role of non-surgical care, including physical therapy, can be very effective. Physical therapy emphasizing scapulothoracic strengthening can actually lead to associated symptom resolution and keep patient within this compensation envelope that was described by Jed Kuhn. One of the most important papers that I use in teaching and in my own practice is this paper that looked at the 5-year outcome of patients treated with chronic pre-existing rotator cuff pathology who became symptomatic and who were recommended to undergo physical therapy. Only 20% less than 80% had surgery, meaning only about 20% had surgery. Most did so in the first 12 weeks of their presentation. That means about 85% of patients remained surgery-free at 5 years. That's a pretty impressive number. And the number one factor that predicted success of non-surgical treatment was the belief that physical therapy would help. It wasn't the size of the tear, the chronicity, the biceps, even the age of the patient, all the things that you and I think about. It was the belief that once they engage in therapy and were told that this is a pre-existing problem that then became symptomatic, the belief that they would get better is what led to the resolution and their ability to coexist with the rotator cuff pathology. This is a case example, and I'm pretty sure you'll be able to hear the audio, but I don't know with certainty. So if one of you would just tell me if you're able to hear the audio on the next one, that would be particularly helpful.
Thank you for doing this. How old are you?
Yeah, we can hear it. No problem.
Right-handed.
Yes, I am.
When did your shoulder symptoms begin?
Probably 3 months ago, maybe. I was snowblowing in the driveway.
Did you have immediate pain with snowblowing, or something that developed over the course of a couple of days?
I remember maybe an immediate like twinge or something, but then, seemed to be fairly okay.
All right, a couple of days later, it got worse.
Didn't get better.
Since then, have you had any treatment, including injections or physical therapy?
No, I'm not.
Does the shoulder pain keep you awake at night?
No.
Are there activities you're having trouble doing with your shoulder?
Well, one of the things I'm worried about is, boats going in the water on the 17th, a lot of winches you're grinding,
Do you
things
think
like
that would
that.
be problematic the way your shoulder is now?
I think right now I can do it.
What's your average pain with activities right now?
I'd say 30%.
Like a 3 kind of thing?
3 out of 10, yeah.
Okay. And what is it about your shoulder that you'd like to see get better?
I've got used to the clicking. I kind of like that.
Okay.
But
Pain?
yeah.
And strength
and
issue?
pain isn't, yeah, and the strength issue. I want to make sure that, I felt confident.
Okay.
And
Okay. Thank you.
Here's his physical
Hold
exam.
arms straight up. All the way up to the sky. Come back down. Good. Arms like this. Roll to the other side like this. Good. Relax. Any pain in here?
no,
Anything underneath my fingertips in here? Good.
no,
When I just bring your arm up this way, does that bother you at all?
no.
No. Okay. Hold your arm like this. Don't let me push. Make it strong. A little bit weak.
Mm-hmm.
Don't let me push. Keep that position. Don't let me, just like that. Don't let me push. Good. Pull in towards your belly. Good. Put your hand on your belly. Keep your elbow forward.
Mm-hmm.
Push. Good. Relax. Okay.
So you can see not a very impressive presentation, but someone who has concern. His x-rays, I would say, are essentially normal. His MRI shows a full thickness rotator cuff tear. It's in good position, no significant atrophy. You argue, I remember when I was in India, people coexist at that time when I was there with a lot of pathology. And I would imagine some of you would say, if this patient showed up in your office, you'd even be wondering why he's there, but he obviously has concern. He had made it to the physician's office. Someone ordered an MRI. He knows he has a tear. He has mild symptoms and lots of concern. So his treatment was a cortisone injection into the subacromial space.
We're now about 6 weeks after your cortisone injection, and you've had about 8 visits to physical therapy. How are you doing?
I think I'm doing quite well.
Do you have any pain whatsoever?
Not much at all.
Do you have any night pain?
No, I sleep.
Okay. Is there anything from a functional perspective you're having difficulties with?
No.
Okay. Would you say your shoulder is close to normal?
I would say it is close to normal. Definitely a lot.
So that patient never came back. He's over a year out and has had complete resolution of his symptoms. So in my opinion, when I'm educating residents and fellows and colleagues, I think that that's probably the most important case study you could have, especially when you consider the economics of surgery, both to the patient and to the system. And it begs the question then, well, why do patients actually have surgery, and what do they want, and and how do we actually make it happen? How do we bring them to a place where they have sufficient reductions in pain and improvements in function? And I would say that if we look across the board, how you and me decide, or you and I decide when a patient should have surgery, the classic indications would be pain, weakness, and a failure of non-surgical treatment like you just saw. And those are the ones who we typically would recommend surgery. And the objectives are kind of twofold. One, to restore anatomy. We want to do something that is durable, sustainable, will not re-tear, and that will subsequently return function to that patient with a high degree of satisfaction. These are the options. You'll hear a bit about some of these through this talk and my talk about the role of managing the irreparable tear with either superior capsular reconstruction or reverse arthroplasty. But I'll stick to repair right now. When you ask patients what they want, and this is another study that we worked on, and I really wanted to get at, when patients come to our office, what is it that they're looking for? And this study, basically through survey pre and post surgically, indicated that patients really had a profound interest in reduced pain and more function, but they would take normal function even in the presence of a little bit of pain. So the important thing is that we typically operate because of pain, but function is very important to patients. And in another study that looked at satisfaction, we felt that our patients felt that 87% that their strength and function were acceptable. So we know in general, it's a very good operation when it comes to assessing clinical outcomes. The other thing that's important, and we often talk about, is what is the role of having an intact versus a persistently torn or re-torn rotator cuff. And we know when you look critically at the data that patients are generally more satisfied when the rotator cuff is intact and it is associated with strength returns. So to say that all patients do well, even if the cuff is not intact, I believe when you look at the literature carefully is not true. And in fact, a healed rotator cuff generally does better than one that has failed. So we ask ourselves, how can we do better? And this is something that we've been talking about for years. And we have spent a lot of time looking at rotator cuff techniques, single row and double row and transosseous equivalents. And there's at least 24 papers that have looked at this with very high levels of evidence that have shown in various instances that one technique is superior or inferior to the next, double row versus single row. And I would say that in some ways it's a bit of a coin toss in terms of whether or not we know with certainty in these techniques. But if in the two meta-analyses that we performed and others have performed, what we found is that when we looked at the best literature and excluded some of the most flawed studies, that double row rotator cuff repair provided superior structural characteristics compared to single row when the literature included levels of evidence 2 or above. So it's my feeling that for the right rotator cuff tears, especially chronic, maybe poor quality tissue, a single full tendon or more, those are the ones that we typically use double row. However, when we're doing side-to-side repairs for chronic retracted L-shaped or reverse L, we will less commonly use double row, and I'll show you that at the end. This concept of double row has led to problems that were unforeseen and are important to understand. If this type of failure where it fails at the muscle tendon junction, leaving tendon on the tuberosity, is a very difficult one to manage. And it's most commonly present when at the time of repair, there's a very short tendon remnant. So it's something to think about. We looked at this biomechanically, and what we learned in abnormal tissue, that we should keep that medial row. If you're going to use a double row, keep the medial row of sutures lateral to the muscle tendon junction. If you put it right at the muscle tendon junction, it may provide a stress riser. So our argument is that you want to keep your sutures somewhat lateral, and through cyclic loading, we learned that these will stay intact more than these at the muscle tendon junction when we go to ultimate failure. Cost is a consideration, and I think especially in countries where implants place a heavy burden on the healthcare system, I think the way you would consider cost is if you know and you believe that a double row repair is the right operation and you weigh that against the cost of revision surgery, arguably the decision would be made in favor of a double row repair for certain tear types.
Thank you.
This is another patient I'll show you.
How old are you? 51. Which shoulder is the problem? Right shoulder. Are you right-handed? I am. This was a specific day that this occurred. Can you tell me briefly what happened?
Sure. About 2 weeks ago, I was in the Bahamas. I was doing some body surfing, went into a big wave, caught the wave pretty well, and I came out with my shoulder dislocated.
Was it replaced or put back into position in an emergency room?
It was.
Okay. And how long was that for?
Probably 45 minutes.
And have you ever had previous problems with your shoulder?
No.
And right now, is your shoulder painful?
Yes.
Okay. Does it keep you awake at night?
Yes.
Okay, and any treatment so far, including therapy or injections or other?
No.
Okay, thank you. You see from both arms forward?
He's bruised because he probably, with his recent accident, tore his biceps.
Painful? Yeah. Okay. Don't let me push. Pull towards your belly. Feel normal here.
Yeah, pretty much.
On this.
Okay.
Does that bother you a lot? Yes, pretty good. All right, I'm not gonna torture you. Okay. We'll come right back down. Okay. Make a muscle like this. Good. Okay. Very well.
X-rays are normal. Here's his MRI imaging, his outlet view. You get a sense of the leading edge. Not a significant amount of atrophy. Sadly, you see a good quality rotator cuff, legitimate tear. I'll just go over a couple technical aspects. I use a beach chair position for rotator cuff, lateral decubitus position for instability. In order to maintain visualization with the properly medically managed patient, you can use relative hypotension, but you definitely need to be careful in people who are normally hypertensive. We will occasionally use epinephrine in the bag. I keep my pressures, my pump pressures somewhere between 50 and 80. I'm typically around 50. And we use radiofrequency devices to perform bursectomies. Very important to determine the tear types, because this just dictates how you repair it. Not necessarily the outcome, but it just helps you decide what you're gonna do to restore the anatomy. This is probably the most common is a crescent type. An L shape is probably really a chronic crescent that just starts to retract, and this would be one where it's almost a reverse L where it gets pulled straight laterally. And then finally, there's a U-shaped tear, which may respond best to a side-to-side repair, followed by its transition into a crescent. So just to give you a sense of the most common things that we see. I don't think it really matters what the name of the tear is, but it helps you understand how to predict your repair pattern. I think it's important, just like when you used to do open surgery, to do your best to minimize tension on the repair. So I intra-articularly will perform a capsulotomy. I'll also often release the posterior capsule. That will help restore internal rotation. Occasionally, we'll perform a rotator interval slide between the subscapularis and the supraspinatus. I hardly ever do a reverse rotator interval slide. This is more to release the coracohumeral ligament. If you do a reverse slide, meaning the one in the back between the supra and the infra, often you end up with a very poor quality piece of tissue. So I kind of like to keep the continuity between the supra and the infraspinatus. But I will occasionally, for a retracted tears, cut across at the level of the coracohumeral ligament. This is just a very basic repair. I think this is a double row of a right shoulder. That's the posterior medial anchor being placed while viewing laterally. There's a lot of different ways for suture management, but whenever you're using sutures and tying through cannulas, just make sure that you keep one suture at a time in the cannula rather than two, because you'll get tangled. And we're just passing a simple to establish the posterior footprint here. Then I'll put in an anchor that has a core suture as well as a heavy gauge tape suture that's used to pass for horizontal mattress. I'll typically use, most of my work is from the back for suture passing. Again, this is a right shoulder. That cannula is coming in anterolaterally. That's the second knotless anchor I'm placing. I place two of them, one anteromedially, one posteriormedially. I place the tapes horizontally, and I use the core suture in the anchor as well. I'll typically tie down the medial row. It just gives me confidence that if anything else fails, I at least know I have my medial row that's present and is strong. So then we'll retrieve one tape from each anchor and dock it anterolaterally and posterolaterally. I have many more videos on my website. This is really for demonstration purposes. Brian Cole MD is my website, and there's a number of teaching videos there that go step by step, but this just gives you a rough idea how we do a double row transosseous equivalent repair with a posterior medial and an anteromedial anchor in an effort to create interconnectivity that is very resistant against rotation. Probably the strongest repair technique available, I would argue. But what I did do is I established the posterior aspect of the rotator interval cable, and then I basically placed an anteromedial and a posterior medial anchor, placed my tapes, tied my core sutures, and crisscross the sutures anterolaterally and posterolaterally. This is him 2 months post-operatively. I know it's very short term.
Now for right shoulder, right? How would you say your pain is now compared to where you were before surgery?
Significantly better.
Good. Are you sleeping at night? I am. Good. And in therapy, have you started strengthening yet?
So range of motion, but I feel like I'm getting stronger. Yeah.
Good. And if you think about the pain you had before surgery compared to what you have now, what would you say?
Not as much. It's probably 20% of what I had before surgery.
Good. And have you bring your arms over your head?
I mean, obviously, this is very short-term follow-up, and you want to be careful in your strength assessments. I'm not going to have him crush it, but just to give you a sense of how he's doing. What about the other pathology? And this is important. The biceps is something that we liberally will manage, especially if there's any involvement of the subscap. Only occasionally we'll do distal clavicle excisions if they're truly symptomatic. Otherwise, I ignore them. A biceps tenodesis, I perform in a subpectoralis fashion through a 2-centimeter incision. I now use these knotless anchors. This is a knotless suture tack, which has 2 tapes, and it's a 1.9 millimeter drill hole. So I'm willing to use this even in collision or contact athletes because it's a small drill hole. It's very efficient because the suture, the needles are swedged on, and been a significant efficient advancement that's cost effective for our practice for biceps tenodesis. The other thing that often gets asked is, look, what's the role of acromioplasty? Is it important? What we showed is that there was no difference at any time point between 6 months and 2 years when a acromioplasty was or was not performed. So this is in totality my algorithm. I use a single row for smaller tears, partial thickness tears where the biology is good. It's very efficient. It's cost effective. I will use a double row like I showed you for larger tears, especially those that involve the supra and the infraspinatus that have larger footprints. Some other intangibles which I think are really interesting and things that we've looked at are the psychological factors. There is a propensity for patients to catastrophize their condition, which you sort of get a sense when you walk in the room who's going to do well and who's not. But while I spent a lot of time discussing the anatomy and the biomechanics of these repairs, there's a number of other factors that relate to a successful outcome, including the sort of psychological aspects of the patient and their likelihood of getting well. So what do we learn? Most patients with rotator cuff tears will never be seen in a physician's office. Non-operative treatment remains an option. Irrespective of the type of surgical treatment, rotator cuff tears repairs result in reliable pain relief and return of function. An intact cuff is correlated with patient strength and satisfaction. And I will use a double row repair for the most common tear configurations. Again, I want to remind you of April 22 through April 24. India is our guest nation for the Arthroscopy meeting in Chicago, and I hope to see many of you there. And I think what I'll do is I'll have you tell me if you would like to continue with the next lecture, or would you like to take a moment and maybe entertain some questions just to break it up.
No, we'll have some questions, Brian, before we jump on next lecture.
Perfect, thank you.
Thank you. That was a wonderful talk, Brian. I'll request the lecture is open for discussion. Dr. Antao?
Mute me.
Yeah.
Brian, very informative, educational lecture for all of us here, especially your clinical examination and history taking, which is very, very important for a clinician like you. And I was wondering, the first patient that you showed, the pain and power of the patient improved a lot. And he said 89% he was better or 90% better. In your mind, you know he has a tear. How long this pain is negative and when does this pain returns?
Yeah, so that's a tough one. I can tell you how long people remain surgery free, but what I can't tell you is how well he's doing clinically.
Yeah.
It's a great question and something that I think we've not done a good enough job. I will tell you he's been satisfied enough to stay out of the office for the time being. I would tell you the literature suggests that between 20 and 40% of them will progress over time. Obviously, the biggest concern is that if we let him go, that he'll end up with a different operation later on at the time he represents than he would right now. And the best time to fix this is now. But when you look at the numbers of individuals who have no pain, that the millions of people where you live, who walk around with rotator cuff pathology and have no idea until they get an MRI, that's somewhat staggering. So I think that it is more likely than not that people will coexist with rotator cuff pathology and do fine. And when they come to us, they're just out of balance. The things that normally help them compensate are dysfunctional. And the one signal of increasing pain was scapulothoracic dysfunction. And if you correct that, even with or without a steroid injection, many people will get better. The biggest challenge is the patient who thinks they're broken and they don't understand why you're not fixing them, because they're like, oh my gosh, I have a tear. I just got this yesterday. You know, I had no pain. I reached up and my shoulder broke. Fix me. And trying to talk that patient into non-surgical care is very challenging. But I firmly believe that this can provide a satisfactory outcome. I can't answer your question to tell you if they have no pain, but I can tell you that they stay out of the office, or maybe they're going somewhere else and getting fixed for all I know. But you can get a lot of people better, but you do have to caution them that it's possible it could get larger over time.
Brian, what clinical test, according to you, is the clinical test, the diagnostic test of rotator cuff tear? Because there has been a very conflicting report as far as the clinical examination of shoulder is concerned. Whether the test drop arm sign, the empty can test, the empty can test in lateral side. So, what do you think is the right test to diagnose a rotator cuff pathology?
While we have often used, looked at EMG, we have a study where we looked at EMG nerve conduction to look when you isolate the supraspinatus. I think the first thing is before you even touch the patient, you can kind of know what's going on. When a patient, just by their history and their age and the chronicity and the physical location of their symptoms, without even touching the patient, I think you can get 80% of the way there, in my opinion. I think the X-ray, which could help differentiate osteoarthritis from rotator cuff, for example, but even that's a distractor because many patients with osteoarthritis have no problems with the osteoarthritis and are symptomatic because of the rotator cuff. When it comes to the physical examination, for example, trying to differentiate, quote, impingement syndrome from rotator cuff pathology. Impingement syndrome is incredibly common in the absence of rotator cuff tears. And they typically will have more pain with passive motion, passive me lifting their arm. When patients have a painful arc, just very simply going in this plane, this painful arc, and they have minimal or just a little bit of scapular dyskinesis, adding that to the history, that's a signal. When we test them, the one challenge I have with the thumb down is that puts the tuberosity underneath the acromion. And if you're looking for pain and weakness, you're most assuredly going to get it in that position. If you want to really test the strength in the absence of the confounding variable of pain, you have two options. You can give them an injection in their subacromial space with lidocaine and then test them, get rid of their pain. Or you can try to do a physical exam where they have rotation that's external in the scapular plane in an effort to take the tuberosity out of the equation to see if they're weak. I think you can make a lot of decisions without an MRI. I think that if you subscribe to those patients who don't necessarily have acute injury or are very young, but the middle to older patient where you know they likely had a chronic pre-existing tear, you can make all your judgment calls sometimes with no x-ray, but let's just say a simple x-ray, a physical exam and a history, and you could treat them as if they have a tear. And if they don't get better, whether you get an MRI or not, if they're dissatisfied, then you're talking about surgery. So I think the physical exam is really important and it's a lost art, but and it's interesting in these times of COVID where we're using telemedicine a lot now, it gets kind of interesting and fun to sort of make these decisions without ever examining the patient, which I think you can do. I don't want to distract and say the physical exam is not important, but pain is a very significant distractor in trying to determine if they have a cuff tear, and you have to eliminate the things and there's a lot of things that mimic each other in the shoulder. In other words, the overlap in pathology that can cause pain, and it's very difficult to assess. I think the best way is give them a lidocaine injection and check their strength then. If you do that and their pain is eliminated, but they're weak, you kind of have a good sense that they have rotator cuff pathology.
Brian, since you talked about the hydrocortisone injection, it is believed that once you give hydrocortisone injection, the pain goes away, but the tear size is often increases. Is it true in a degenerative tear?
Yeah, so if you turn to the literature and you believe the literature, what it tells us is about 20 to 40% will enlarge over 3 to 5 years. So the fact of the matter is, once you're known to have a tear, about a third of them over 5 years will progress. The challenge is that they may progress and pain may never come back for a very long time. So the anatomy is disconnected from the clinical presentation. So it leaves you lots of room for decision making. You could argue that age is your decision making, that someone who's much older will not live long enough for their tear to become problematic, where you would have to offer them a different solution. Whereas someone who's much younger, all things being equal, you might push the envelope to operate on sooner because they have a much longer period of time, presumably, to live with their problem, where they're more likely to progress. So that's where age might become relevant in the decision making. But progression might happen, but it also might not happen. And re-tears often happen. So you're telling a patient, let's fix this to prevent progression, when 25% of them show anatomic re-tears and can progress anyway. So those are the things you're weighing it against. It's nothing, none of this is a foregone conclusion that you solve their problem once you fix it. The reason they tore to begin with is because their biology is terrible. It's just something that's attritional in nature.
There is a question on YouTube regarding number of steroid injections and the interval between your steroid injections and the surgery, rotator cuff surgery. When do you decide on rotator cuff surgery post injection, and how many injections you like to give?
Unlike the knee for osteoarthritis, where I will more liberally use a steroid if they get 3 months or more relief, in the shoulder, they really have to get a significant benefit for an extended period of time. If they are medically morbid and can't have surgery, I would change that rule. But if it's someone who can tolerate surgery, I may give one and hope that they get, I won't, unlike the knee where I may do it every 3 to 4 months or 5 months, in the shoulder, I'll do it once. And I usually, if I'm gonna operate, make them wait 3 months before surgery. And I won't continue to repeat it. If they return again in a year and they say, I loved it, give me another one, which happens not infrequently, I'll do it. If they come back in 3 to 6 months, I'm like, look, I don't want to keep poisoning the shoulder. I think it's safe to do it, but I'm not sure you're going to get any longer benefit. If you're dissatisfied now, you are likely to be dissatisfied again in 3 to 6 months. So what are your thoughts on fixing it?
Brian, there was one case you showed where there was ecchymosis in the shoulder. At the X-ray was normal, MRI was normal. What?
No, that MRI, he had a large supraspinatus tear, but he had a pre-existing tear and he tore his biceps.
Okay, the ecchymosis because of the biceps.
Yeah, he had a long-standing tear and presented because of an acute injury with a biceps tendon tear.
All right. In all cases, you do posterior capsular release, anterior capsular release, interval release. In all cases, or how do you decide when you want?
No, I don't do it at all. I don't do it at all. I think that many of these are very pliable and easy to fix under minimal tension. So I do it in the chronic cases that need to be mobilized. And I'll basically assess them pre-surgically for their range of motion. I'll check their internal rotation and their external rotation. And I'll show you a case of an example that we'll go over together with the panelists. But I would say maybe 30% of the time I do that at most.
We have many cases to discuss, Dr. Antao. I think we should proceed with the next lecture, because in the end, we are going to have a good panel discussion with the cases from Brian Cole.
All right.
Yeah, Brian, we can proceed with your next talk on massive rotator cuff, the technical pulse.
Thank you. Massive tear. Oh, it says I'm muted.
Yeah, we can hear you.
Oh, okay, fine. The problem with the massive tear is that there are several options to management. There's many things that have to be taken into consideration, and choosing can be particularly difficult. The options that we will still entertain today include all of these: non-surgical, debridement, repair, extracellular matrix to bridge it, superior capsular reconstruction, recently submitted for FDA approval subacromial balloon, tendon transfers, and reverse arthroplasty. And the reason I like this topic, it's not unlike why I got particularly interested in articular cartilage management and transplants, is that this is kind of the most, in my mind, the most fun to talk about intellectually, And it's fascinating to me how you and me can be in the office and come up with a different decision. And it's also fascinating that you can choose a different decision and still get it right. There's many ways to get it right in this setting. It's important to understand that while it's provocative to do superior capsular reconstruction for chronic massive tears, that the results of repair of chronic massive 2 tendon tears are actually pretty good. It can reverse pseudoparalysis. You can have a maintained MRI for the anatomy at 1 year, and patient satisfaction with repair of a chronic, otherwise presumed physiologically irreparable tear can actually achieve a good or excellent result. This is an example of a 72-year-old with a chronic tear. And it's pretty bad. And I'll show you this case later on, what he started with. But this just gives you a sense of very, very poor biology, some proximal migration, no arthritis. And many would argue that this is just a futile situation. And I just did a side-to-side repair of this U shape and turned it into a crescent, fixed it laterally. This is the repair. And this is his post-op physical exam. He had pseudoparalysis to begin with. The one on this video here is what he looked like pre-surgically. Okay, that's him pre-surgically. And this is him post-operatively after repair of this very, very poor quality tissue. Complete reversal of pseudoparalysis. And that's because of the basic principles of restoring the force couple around the shoulder. You don't have to have a normal rotator cuff to have normal function. Again, 6 million people have rotator cuff tears and are functioning fine. So what we did is we basically just put him over the edge. We moved the lever forward so that he could rehab properly and get the things that are working normally intact, and get them functioning normally. I would argue that repairing this was only half of the solution. It was the rehabilitation and the reductions in pain that made him become compensated when he was previously decompensated to give him the result he was looking for. But what if it looks like this? I could talk all day long about repair, but in this revision situation, I say there's just nobody home. This is a young patient with no glenohumeral arthritis with an intact subscap. She's 55 to 60 years old. What do you do in this situation? So some things to consider: that the primary revision of the irreparable rotator cuff with arthritis is a factor in decision-making. When their active forward elevation is greater than 90, when they have pain with normal function, patients that are younger than 65, and the complications and the cost. These are all mitigating factors when you're trying to decide what to do here. And we could spend the next 5 weeks discussing all of these factors that go through our minds when we are deciding. It's not just the MRI, it's not just the X-ray, it's all of these factors and probably many more that help us to make a decision on how to manage the irreparable rotator cuff. And you kind of have to add it all up and say, look, where am I going to end up with a SCR or reverse in a setting where it's irreparable? So superior capsular reconstruction is a fairly simple concept that prevents superior migration of the humerus on the glenoid in the absence of a rotator cuff, functioning rotator cuff. It doesn't change glenohumeral force, but it acts basically as a tether or tenodesis effect, preventing proximal migration, allowing the muscles that are intact, in the 6 million people that run around with rotator cuff tears and don't know it, to function better. The indications are symptomatic, irreparable, super and infraspinatus, but they have to have an intact subscap and minimal to no glenohumeral arthritis. We've learned that they really should not have static or dynamic proximal migration that's greater than a Hamada grade 3. Essentially, if they're off center, you can do it, but if they start riding up and are nearly touching, or they have acetabularization of the acromion, those patients historically do not do well with superior capsular reconstruction. So the two contraindications to get a good result are advanced rotator cuff arthropathy, even in the absence of arthritis, but with proximal migration, or an absent subscap. A superior capsular reconstruction can reverse pseudoparalysis and pain and improve function, but it really cannot treat advanced rotator cuff arthropathy. It cannot improve lost passive range of motion. And it cannot improve strength dramatically when that strength reduction is unrelated to pain. If it relieves pain, strength can actually improve. But the alternative is not actually true. We've had a significant evolution in techniques towards thicker grafts using a transosseous equivalent laterally, 3 independent anchors medially. Peter Millett has published 2 studies that basically have shown us that the use of these anchors medially up to 1.5 centimeters on the top of the glenoid actually are very safe. And the technique has evolved from a suture shuttling to 3 independent anchors medially that we just place percutaneously, typically through an advisor's portal. Very safe. These are the medial anchors for superior capsular reconstruction being placed through an advisor's portal. There are 3 portals, patients in a beach chair position, scope is looking laterally. Those are the 3 anchors. There's one at 10 o'clock, one at 12 o'clock, and one at 1 or 2 o'clock. And we're basically trying to spread them out over the top of the glenoid between the intact subscap and the teres posteriorly, because this is a supra and an infraspinatus irreparable tear. Like I showed you that double row technique for a standard rotator cuff, we do the same thing here. We place a knotless anchor with a suture tape in the eyelet anterior medially, and we place one posterior medially. So this is a right shoulder looking lateral, posteriorly, placing the anchor anterior medially and posterior laterally. Graft measurement and tensioning is important. These sutures medially are used to measure the distances between them, because we're going to take these measurements and apply them to the graft. This is a dermal graft that's 3 millimeters in thickness or greater. So we take measurements arthroscopically to determine how wide the graft should be over the top of the glenoid. We also take those same measurements to go medial laterally. The graft is then prepared. We add about 8 millimeters in the front, 8 millimeters in the back, 8 millimeters medially and laterally. I punch 2 holes along the lateral side of the graft, and that's for my suture tapes to go through. The 3 marks medially are basically where we're going to place our sutures from those medial anchors. These are the medial anchor sutures that are being retrieved through the cannula laterally. I'm looking from the back and retrieving laterally. And these sutures are just going to be passed through the graft medially. We just retrieve one at a time, identifying the suture passing. Here, again, let's see. Here then, we've passed our sutures through the graft, and we're introducing it through a cannula. You can see the tape sutures laterally. You see the 3 sutures that have been placed in horizontal matches medially through the graft. We introduced it by grabbing it medially over the top of the glenoid and tightening these sutures medially over here. That basically just pulls the graft into position. And then we basically complete the transosseous equivalent with an anterior lateral and a posterior lateral swivel lock anchor in this case, in an effort to secure the graft down to the tuberosity. So what can a supracapsular reconstruction do? One of the first reports by Mahata suggested improvements in all the things that you typically look at. If you look at the available literature, basically you can see improved visual analogs, simple shoulder tests, SANES. It can reverse pseudoparalysis. Return to sport is even possible. And satisfaction rates are very, very high. I'll just give you a case example.
What was your average pain prior to your surgery? Normally about 4. And you had trouble with pain. Yes. And how long was your surgery? Probably about 4 or 5 years. And what about function? Was function a problem with your surgery? And since your surgery, sitting where you are today, what would you rate your average pain now? 0. And in terms of function, with 100 being normal, how would you rate your function? I would say 85. And neck pain is gone. Wow. Okay. And knowing what you know now, would you do it again? Yes. Okay. Thank you.
Here's her physical exam. She was actually pseudoparalytic to start. You can see she's the proper age. I show you her pre and post x-rays below. Keep in mind that you don't always see improvements in the coronal humeral interval. I'm not sure I can always rely on that, but the important thing is clinically she had significant improvement. So what about reverse, the other end of the equation? The results are excellent in patients over 65 with true rotator cuff arthropathy and pseudoparalysis. They end up with less pain and more function and more strength, but it's at a cost. There's a 15 to 30% complication rate and a 7 to 12% revision rate. So these are the ends of the spectrum I want you to think about. And these are when the decision-making is very hard, the so-called black and white. On the left, I'll track you through the decision-making for someone who's a perfect candidate for reverse. And then I'll track you through a candidate on the right who's a very good candidate for superior capsular reconstruction. So patients with irreparable tears with Hamada grade 3 are physiologically older, lower demand, where they have a subscap or teres that's out, that'd be the perfect candidate. Alternatively, those who have an irreparable tear, that's the common denominator, but they don't have arthropathy. They have less than Hamada grade 3 changes, physiologically younger but higher demand, where the subscap is intact. This gentleman on the left is pseudoparalytic, has obvious evidence of previous rotator cuff repair, has significant atrophy and a subscap tear. Patient on the right, much younger, maybe a little proximal migration on the MRI, but not on the X-ray, who has pretty good function and is not pseudoparalytic. Very good candidate for superior capsular reconstruction compared to the reverse on the one on the left. Give you another case example. This is a 58-year-old with right shoulder pain. Prior massive rotator cuff repair, never got better. He's been unresponsive to additional non-surgical treatment, has reduced forward elevation and strength. His subscap is intact, but he has a chronic irreparable supra and infraspinatus tear. He's probably physiologically older than 58. He and I are actually nearly the same age. That being said, he's still less than 65. Here's his shoulder arthroscopically. And here's an anchor that pulled out immediately. And essentially, I would say arguably nobody home. In other words, nothing to fix. So he ended up with a superior capsular reconstruction despite having a previous rotator cuff repair that failed, which to me is my most common indication in the properly aged patient. Just taking measurements, medial to lateral, anterior to posterior. This is one of my first cases. And then introducing the graft, tying it down medially. This is an old technique of a suture shuttle technique, which I do not do anymore. I use independent anchors now. And that's the graft, and then we'll repair it posteriorly to the teres and anteriorly to the subscap. And this is function postoperatively. So what about the other end of the spectrum? This is a study that we did years ago with following rotator cuff repairs, but I used this patient who was part of my study. She had a massive 2 tendon tear on both shoulders in 1997. In 2010, I had her back for follow-up, and she was still doing beautifully. I had repeated her MRI, and the MRI showed the same massive tear that I saw in 1997, but she was perfectly happy in 2010, coexisting with her failed 2 tendon tears.
Okay, thank you for agreeing to do this.
Oh, you're welcome.
It's your right shoulder, correct?
Yes,
And how many years ago was your right shoulder rotator cuff fixed?
20 right now.
Well, for 20 years, right?
Mhm.
And after that repair, when did you first become symptomatic or having problems with the shoulder again?
May 31st, 2014.
And what happened?
I was hit in an automobile accident. I was standing still.
Okay, and you feel like you jarred your arm on something again, and then from that point forward, despite injection, physical therapy, it has not gotten better. And what is your number one complaint?
Well, the pain, especially I can't sleep. I can't, it just keeps me awake. I have to roll over. I have to hold on to it. And it's not as, I can't lift it up as high as I could with it. I could do anything with the rotator cuff.
Okay, thank you.
So lovely woman. I repaired both her shoulders in 97. In 2010, I saw her. She had massive re-tears, but was still happy. She has a motor vehicle accident, and I would argue, you know, again, these can be liability cases in the United States. If someone said, did the motor vehicle accident cause her tear? I would say no. Did it aggravate her pre-existing condition? Yes. She failed additional attempts at non-surgical treatment, and she ends up here. And I think you know where this case is heading. She has osteoarthritis. Maybe she's Hamada 2, but you know, given her age and what she's been through, I was not about to do a supracapsular reconstruction. So she had a reverse arthroplasty. And this is her after her arthroplasty. So this is provocative because it's fast, it's easy, and maybe more expensive, but in this patient group, this is low-hanging fruit to make someone very, very happy. This is another one.
Hey, Dr. Cole, this is Sister Smigielski. Look at, looking good, feeling fine. Thanks a lot. Oh. Hey, check this action.
That's after a reverse arthroplasty.
Okay. All right.
So what about the patients who are in between, the gray zone? And this is where you and I struggle in the office. There's 3 what I call gray areas. One is a massive rotator cuff tear without arthritis. Two is a failed rotator cuff tear without arthritis. And three is age less than 65. These three categories have shown to be the most challenging in our literature with reverse arthroplasty. So if you're looking to do a superior capsular reconstruction and avoid arthroplasty, this is the group that is the one that you should pay attention to. A massive tear without arthritis, a failed repair without arthritis, and age less than 65. Also keep in mind the complication rate with reverse is going to be more significant and more frequent. A complication rate after a supracapsular reconstruction, for example, is usually an arthroscopic repair or an arthroscopic debridement if it's infection. It's much more catastrophic for fracture or dislocation after a reverse. Particularly relevant is the cost. I would tell you that the cost of reverse is considerably more than a supracapsular reconstruction. This is a 70-year-old with several years of shoulder pain, had one cortisone injection and physical therapy that provided relief, had a recent fall and then another cortisone injection, presents with pain that's 3 out of 10 in the right shoulder, and the primary goal is to have improved function and less pain. This is his physical exam.
Nice. Good, come back down. Bring your arm back like this. Hold that position. Don't let me push. Make it strong. Be weak still. Hold it like this. Don't let me push. Can you hold it back like that? Maintain that.
So pseudoparalysis. This is the MRI. And I'm showing you this because this is something that you and I will have available, I think, in the next year or two. So obviously one you'd think about, look, do I do a reverse? Do I do SCR? I don't know. This is the pathology. Maybe that's repairable. He's already had one repair. Maybe you do a side-to-side re-repair. That's an option. So to say it's totally irreparable, I could get that back, I think. What would you do in this case? This case, we used the patient was part of a clinical study where we placed the orthospace balloon. We're doing viewing from the back, measuring from the side, introducing arthroscopically the resorbable balloon that will be filled with saline. And this is a subject of a clinical study that has a CE mark, I believe, in Europe, but not approved yet in the United States. It's not a permanent replacement or arthroplasty. It basically is a spacer that I believe makes a patient more rehab tolerant. It puts this patient who is symptomatic in the 65 or older group, one of the 6 million who actually is symptomatic, and makes him asymptomatic because he can rehab more responsibly and take advantage of the things that are actually working. So I think it really just makes them a better candidate to respond to non-surgical care, quite frankly. People say, well, it's not permanent, that's a problem. It doesn't need to be permanent. You need to get this patient back into their physiologic envelope where they're more functioning and they're functioning more optimally with the things that are normally working. And that's what this balloon probably does.
Now that you're 7 months post-operative, how is your pain compared to pre-op?
0.
And in terms of function, how would you describe your function compared to where you were before your surgery?
I can use my arm. It's the only apprehension or the only drawback is getting the strength back and using the arm to lift weights above my head.
Okay. Other than that, though, are you satisfied with the outcome?
Oh, yes.
Okay. And how long did it take before you had pain relief compared to the preoperative pain?
Gosh, it seemed like it just happened right away. It was gone.
Okay. Thank you. Both arms up over your head for me. Good. Come back down. Arms at your side. Roll to the outside. Make it strong. Don't let me push. Good. Relax. Don't let me push. Make it strong. Good. Turn around and reach up behind your back. Keep turning around. Keep going along this way. Turn around. Actually face the wall. Good. Both arms up behind your back. Let me see you do that one. Excellent.
So pretty profound. Here's a couple more.
Back down. Reach up. Turn around and reach up behind your back. Okay. Relax.
All very similar clinical situations. What are the results? It's still pretty early, but I will tell you that our clinical study and the results are being looked at very critically now for the FDA, but they've been surprisingly favorable. So pain, active range of motion weakness, and pseudoparalysis can be effectively treated by both supracapsular reconstruction and reverse. Passive range of motion loss and escape are very difficult to treat with an SCR. That's a good candidate for reverse. I think it's important to avoid reverse for your younger patients who have longer time to live with a reverse implant. Those who have no arthritis but a previous rotator cuff repair don't do as well. I think sometimes you have to go younger with a reverse when there's no subscap or there's escape. where there's greater than 3 Hamada change, but it is associated with a higher incidence and more severe complications. I do believe that supracapsular reconstruction has increasing evidence, but like most of these procedures, we'd like to see long-term follow-up, but even in the short intermediate term, I've been very happy with the outcomes when it's properly indicated. Thank you very much for your attention, and we can take a couple of minutes of questions.
Yes. Thank you, Brian, for a wonderful talk on this hot topic, the massive rotator cuff repair, and what is the current strategy. Anybody has a question?
Brian,
Dr. Antao, Dr. Sanjay Trivedi.
Brian, you talked about the balloon. Does the balloon deflate anytime there, or the products of degeneration or degradation affects the patient, and how long the pain relief lasts?
So success rates have been in the near-term literature have been greater than 75% for pain relief. The balloon does not last; it's resorbable. I think it's around a 3-month time frame that the balloon will at least violate and go away. That's why I was explaining the benefit is not as a permanent spacer, but the benefit is, in my opinion, to get them rehab enabled. In other words, it takes a patient who's rehab decompensated. Maybe it brings the head down temporarily. It allows the front and the back to start doing the right thing. Again, it makes them behave, transition from a decompensated patient with a chronic massive tear, and it turns them into the patient with a chronic massive tear who's now compensated. That's all it does. It takes the rehab dysfunctional, all those patients who are normally doing great with rotator cuff tears, it takes the patient who's not doing great and makes them do great because it gives them more biomechanically sound anatomy, at least temporarily, so that everything else that's functioning can kick back in. That's the way I think it works.
Dr. Brian, have you ever used the facial atta graft for SCR?
I have not. I think the advantage of it is that it's clearly thicker. I actually wonder how, with my techniques, I could even do it technically, because passing sutures through a graft that's that thick can be a challenge. But I choose grafts from the dermis that are 3 millimeters or thicker. I would tell you that economically, it's probably much more responsible to use the TFL, and we know it works. And some would argue that it works better. So I don't have any problem doing it, but the morbidity I'd like to avoid. And we've been very happy. Maybe we have 10% inferior results with our technique compared to Hamada. Maybe he's a better surgeon. It could be a lot of reasons, but clearly his results have been very good with the use of TFL. And a lot of it people attribute to thickness of the graft.
And dermal allograft, how much thickness you are using?
No thinner than 3 millimeters.
3 millimeters.
Correct.
Okay.
But it's expensive.
And when you think of tendon transfer,
I hardly ever do it now. I'm done with tendon transfer. Maybe I'm not good enough at it, but when I trained with JP Warner years ago, I felt that tendon transfer was no more than a 50-50 option. Now with newer techniques, trapezius and so forth, I don't do them, so I can't comment. But those who do them, Dr. Krishnan and others, are getting excellent results. So I have no problem with it. I'm getting very good results with my own treatment algorithm, but I would never. But I think they may get better results with external rotation, for example. It provides another option. So I think those who are comfortable doing it, it's a cost-effective measure. I have no problem with the technique.
Brian, hello. I think there is a voice echo.
Sir, you mute your that Roshan Wade. Yeah, that's okay.
Brian,
go ahead.
Yeah, the issue here is whenever you're doing a hello, I think there's some voice problem. You can go ahead with something.
I can hear you. It's not bad.
Brian, hi. When you have a big tear in, say, patient age group 60 and questionable infiltration, fatty infiltration into the muscle, and how long do you think the pain and improvement would last? So what is the longevity of such tear generally? What do you tell patient prognostically, that how well or how long you can be nearly pain free?
With which procedure?
With the repair.
Primary repair?
Primary repair.
I guess I would say that I tell them there's about a 25 to 40% failure rate over time for massive repairs. But I'm unable to answer the question, how long it's likely to last. That's the honest answer. I know that the failure rates are around 25% at some point over the course for that patient. In other words, they will represent to my office about 25% of the time within 10 years. The degree of pain relief followed over 2 years, I don't have that data. There's about an 85% improvement at 2 years. There's about a 75% intact rate at 2 years. I can only tell you they're not coming back to me more than 25% of the time after 2 years. That's all I got. I wish I could answer that question more intelligently.
Brian, can I ask you a question? If you cross the Atlantic, you see a lot of tenotomies. What is the percentage of tenotomy versus tenodesis in your scenario with you?
I probably do tenotomy 10% of the time, and that's usually in very overweight elderly people. I fix everyone else because it just takes the negative margin out of the equation that is associated with cramping or persistent pain or cosmetic deformity. It's such an easy operation to do subpectorally. Most will appreciate the cosmesis and prevents the chance of cramping and otherwise. If they're very obese, flabby arms, medically morbid, I'm worried about the added restriction post-operatively for 6 weeks, I will do a tenotomy. But maybe that's 10, 15% of the time. I just don't want them to come back and complain about their tenotomy. So I'm taking it out of the equation most of the time and doing a tenodesis.
So the decision does not depend upon the disease of the biceps.
Well, that's another question. That's a great question. So I guess the question is, you asked me about the frequency of tenodesis to tenotomy. What you didn't ask is the frequency of biceps treatment in massive tears. I would say in massive tears, I'm probably 85% of the time doing it, independent of how it looks, right or wrong.
Brian, I have a question regarding the dynamic structure of rotator cuff. When you try to do the superior capsular reconstruction or spacer, actually you are trying to recreate the dynamic structure with a non-dynamic tissue. So how does you compare both this with the function of the rotator cuff? Just the spacer effect or something more to it?
I think it's in and of itself, it is not dynamic. I think it's a tenodesis effect that allows the intact musculature to do its job. That's why that one slide I showed you about the incidence of rotator cuff, we always start our talks with anatomy and basic science and epidemiology. And most times it offers no value, quite frankly. That one slide is the most telling picture of the dynamics of, not the dynamics, but the spirit of rotator cuff disease is embodied in that one slide that talks about how many people walk around with rotator cuff tears and are not having surgery. And it speaks to why we do well without surgery when they become symptomatic. And it speaks to why we do well when we do surgery, even when they fail anatomically. So the SCR enables someone who is rehab deficient to then become proficient at rehab. And they are doing well because they've now recompensated from a decompensated state, because they are not riding, when the deltoid pulls, they are less likely to go up as far, or maybe not at all, depending on how good the operation is, so that the stuff that's intact in the front and the back can do its thing. If the surgery matters and is actually having the effect, and it's not a placebo effect, it's not working because it has dynamic function. Think about all the patients you have seen with massive cuff tears who come in your office like this, and you can't believe it. They have no subscap sometimes, no supra, no infra, and they're going like this. Why are they doing that? They're doing that because the things that are intact are well compensated. That's my answer to that.
Question, can I ask question?
Please.
Yeah, very cool. I've done a lot of cases, so superior capsular reconstruction with facial data. So with your experience, what are the important steps to execute superior capsular reconstruction in a proper way? because each step is very important. Anchors are very important. Tightness important. Measurement is important. What is your opinion and steps?
Yeah, so let me give you one answer, which would be, it'll be hard to address that and without taking up too much time. So what I'd like to tell you to first do is, my website is briancolemd.com. And there are 2 or 3 live surgeries there for SCR. And I did my first one in front of like 1,500 people. And that was really unnerving because when that was earlier in my career, and there is a learning curve to this operation. I used to dread it because it was just so many steps, and it's expensive and it's time consuming, and it's awful when it goes south while you're in the operating room. Now I actually really enjoy it. It's a technical challenge, but I try to make it more and more perfect every time I do it. And I would say that probably one of the most important things, advancements in the technique, have been using independent anchors medially, so that if one pulls out, the whole thing doesn't become a disaster. If you do the sutures interconnected and you do a shuttle, if one pulls out, you're screwed. That's it. You're done. You got to start over. If one of these pulls out, you can replace it with a push lock or knotless anchor. You can do something arthroscopically to salvage that one place where it failed. So independent anchors medially has been a very significant advancement. Number 2, a thicker graft. Clearly, Hamada is doing extremely well because his grafts are thicker. 3 is patient selection, not in this order, by the way. Choosing the wrong patient, you're not going to get a good result. So an intact subscap without arthritis, very basic. 4, proper tension. We talk about a timeout, putting the arm in the right position, about 30 degrees of abduction, a little bit of forward elevation and neutral rotation. And take your measurements in that position so that the graft has proper tension. If the graft is too boggy or too loose, it's not going to give you the tenodesis effect. The other thing is repairing it in the front and the back. If you think of Poisson's ratio, if you just fix it in this plane, but you don't tension the graft in this plane, there's not enough tension in the entire construct to lead to a functional graft. So I have found that it's very gratifying to place sutures in the front and the back after I've done them inside the medial and the lateral side. Most of us are very happy just to achieve that. And like, I'm done, it looks good. But if you really want to give them a good result, make sure it's under proper tension, and you can improve that tension by your sutures in the front and the back, and you can stretch the graft this way after it's already been stretched in this plane. And that's probably the best I can tell you right now, but I would say I point out all of those things and some other additional features in the videos from the live surgery.
We'll take last question before we start this lecture. Yes, Dr. Antao?
You put a non-living tissue between 2 living tissues, and you nicely explain about the tension front and back and side to side. Technically, it must be quite challenging, right?
To do the operation?
Yeah.
It used to be. Now it's fun. I hated it before. I did, because I think you've come to visit me before. Yeah. And I know many of you because I've seen you in Chicago. I run a pretty busy operating room, and I want to be efficient and on time, and I don't like inconveniencing patients. So I do my best to really stay on time. Patients haven't eaten, they're ornery, they're scared, they're anxious. So I take that very seriously, and it's a burden I carry all day, every day in the operating room to make people happy. So when I used to do these cases, it was like, well, it's either going to be plus or minus 1 hour, and you really don't have that luxury when you're running, the kind of case volumes that we do, when you want everything to be perfect. So I would argue that now technically it's fun, and I don't have much anxiety, and it's about an hour to hour and 15 minutes from beginning to end almost every time. But that's because I've made, I think, almost every mistake. Although I made a new mistake last week. I found a new one, but I've done like everything to make it hard. And then I figure out how to get out of trouble, and I kind of know mentally when I'm going to get in trouble. I've cut sutures, I've broken sutures, I've pulled out anchors, I've undersized, I've oversized the graft. Last week when I was using the graft introducer, I grabbed inadvertently the suture in one of the 3 anchor sutures in the medial row was wrapped around the tip of the introducer. And I couldn't get the introducer out. After I put the graft in, I couldn't get the introducer out of the shoulder. I'm watching it come out of the cannula, but I didn't see that the suture was wrapped around it. And like most of us in orthopedics, when we can't do something, we just pull harder, right? You know, we just pull harder. I didn't do that. I stopped, like, something is really wrong. I cannot figure out why I can't get the introducer out of the shoulder. And I changed my view, and I saw that the suture from the medial anchor was wrapped around the end of the introducer. Had never done that before. But if I would have gotten impatient and just pulled harder, I would have pulled the anchor and the patch out. After 45 minutes of work, I would have destroyed the entire operation, would have had to start over. So I guess if you do enough of them, that's why the learning curves are so important, because the learning curves teach us behaviorally. Once you make a mistake, you know why you made the mistake, you usually don't do it again because you know how you got to that bad place. It's just when the new ones happen. If you watch my video, the first demo I did, I used to cut the passport cannula before I introduced the graft. I would cut the passport cannula so it would make it easier to put the graft in. The downside is the fluid starts to extravasate and it's a hot mess. But I also, when I did that on the video, I cut one of my sutures inside from the medial row, and I couldn't figure out till the end of the case. I was mentally trying to retrace how I cut it. And I just did such a stupid thing. I used my Mets, and I had the 3 sutures outside the cannula from the medial row up high against the cannula. And I was trying to cut the cannula so that I'd have more space to put the graft in. And I cut a suture. So I'll never do that again. Now I don't even open the cannula up. I can get it in with the proper grasper. So we learn from our mistakes.
No wonder you're a speedo. You run from 1, 2, 3, 1, 2, 3, and suddenly you're lost. I don't know. That's the way you go to see the patient. I was wondering where you are.
So that's a very good tip, and practice makes man perfect, as said by many people. I think Brian will go on to your last talk on orthobiologics, and then we'll go on case discussions.
Yeah, and this is a shorter lecture, so. But I appreciate your patience, and I know it's not easy to listen to one person this long. Okay. So I'll just give you a brief overview, and I think it requires a brief overview of where we are with rotator cuff augmentation and trying to improve the biology here. So there's a great book by Atul Gawande called Being Mortal. And this is a book that talks about how we age and disease states and how we intervene on disease states. But there's a statement in there. He says we're all kind of just, as we age, we're sort of rotting from the inside out. And I think that that's really appropriate when you think about rotator cuff pathology. Every decade of life, we get another 10% incidence because we're simply rotting from the inside out. This is an attritional degenerative problem. And while all of these things on the left create these biologic challenges, we're failing just because as we age, our tissue quality decreases. So we beat ourselves up when we repair the rotator cuff and a year later it's retorn. It's a lot like doing a bucket handle meniscus repair that occurs in isolation in an 18-year-old soccer player. They tear, low energy injury, you repair it, and they re-tear 2 and 5 times because they tore the first time because it's more bad biology. It's the same thing in the rotator cuff. No matter how good we are with the technology, the biology still is terrible. And it re-tears because the biology is terrible. And placing sutures doesn't reverse the biology. We spend a lot of time on what happens at time equals 0 to do the best job we can when we completely are inept at managing the biology. I've already showed you that patients with healed rotator cuff tears have better strength and better satisfaction. So if we could reduce the number of re-tears, we'd probably be a lot happier. We'd love to reestablish the emphasis, that fibrocartilage transition to mineralized bone, but we don't do a very good job of that. Mostly what we get is reactive scar tissue and a failure to recreate that mineralized fibrocartilage. And it happens in part because we heal with fibrosis or scar in continuity. We heal with fibrosis rather than tissue regeneration. Now, there's 2 ways to manage that. We can use scaffolds, and I'm not going to talk about scaffolds, but we can use them as an extracellular matrix to either reinforce the repair or extend the repair, or in the case of an SCR, be the entire repair. But we could also use biologics to restore the structural properties. And that could be cells or signals, growth factors or molecules or soluble factors. But this concept of tissue engineering has remained elusive, and it requires lots of things. It requires cells, It'll require growth factors. It'll require scaffolds and something to help restore proper blood flow. That's really the only way we're going to achieve this concept of true tissue engineering. The reality is we don't have a lot at our disposal. Right now, we just have in reality, PRP and bone marrow concentrate. Focusing on PRP, when we looked in the laboratory at its effects on degenerative rotator cuff tendon, we found that leukocyte-poor PRP promoted collagen synthesis, and it actually decreased catabolic cytokines when we compared it in culture to leukocyte-rich PRP using diseased tendons. More importantly, PRP is a signal for mesenchymal stem cells and the growth factors that they come with. We know from these various studies that MSCs will be drawn to the area when PRP is present. It will cause them to divide and undergo mitosis. We also know that if you think about a poor man's PRP, this is something that's been lost in the literature, that if you just abrade the surface, Steve Snyder's so-called crimson duvet, when you do a marrow stimulation at the tuberosity, there may actually be some intrinsic benefit. And this is a very low cost way to provide blood to the area. The take home of PRP with rotator cuff pathology is that double row repairs, small and medium size, do very well and better than those treated without PRP. There's a number of studies, very good research, and the general take home is it might provide an advantage when used intraoperatively to augment double row repairs of small and medium sized tears. Now, there have been some alternative uses of PRP. One study looked at the interstitial injection of PRP into the healing of partial thickness tears, and it didn't have an effect. Another study looked at the use of PRP postoperatively after rotator cuff repair, and there was no change in function. So then what about these medicinal signaling cells? I stopped using the term stem cell for my patients because it's a little bit divisive. They have this mental image that we can rewind the clock by adding so-called stem cells. Stem cells function best in vitro. They don't really function as stem cells when we use them in vivo. They most likely present an opportunity for growth factors to promote angiogenesis and mitosis and maybe anti-scarring, maybe more importantly, anti-inflammatory or modulating the immune system. But they don't rewind the clock per se. Philippe Pernigau showed us that the presence of stem cells in patients with rotator cuff tears is reduced. Not sure if that's the chicken or the egg, but at the tendon bone interface, those who had a symptomatic rotator cuff tear had fewer MSCs in that region. There's some studies that we've done that looked at gene expression of progenitor cells isolated in the animal models. And these cells can be cultured from the rotator cuff tendon, the muscle, and the muscle tendon junction. And we identified similar progenitor cells with gene expression at the tendon and the muscle tendon junction. And at least it helps identify a baseline that we know that these cells are present in intact and diseased tendon. There has been some work in animal models applying MSCs for rat rotator cuff repairs. And the take home was that the cells alone really didn't do a whole lot, and that it suggests that we probably need some soluble factors and maybe a scaffold and maybe something more than just cells to do a good job. There have been a couple of clinical studies. Pernigau is the most often quoted study looking at patients 45 who had bone marrow concentrate at a very high concentration and 45 who did not. These were taken from the anterior superior iliac spine. The bone marrow concentrate was placed between the tendon and the bone. And at 10 years, he had profound results. 87% were intact versus 44% at 10 years when bone marrow concentrate was not used. Another study looking at adipose tissue with an anatomic endpoint of MRI showed a 28% re-tear rate without adipose tissue versus a 14% with adipose tissue. So there's a suggestion that maybe there's something there. This is our study that's not yet published or peer-reviewed, but it's been presented. It's a prospective randomized trial using biologic augmentation with bone marrow concentrate in patients undergoing arthroscopic rotator cuff repair. And we had 20 patients in the bone marrow concentrate group and 28 controls. And basically when we used the 5-level SIGAIA score, we had about a 1-point improvement at 1 year MRIs. there was a significant and strong association between bone marrow concentrate and a lower or improved SIGIA score by MRI at 1 year. That's the best I can tell you right now. The results are continuing to be analyzed. There are some other options. People have looked at the use of MSCs like PRP to inject intratendinously for partial thickness rotator cuff tears. Now, between me and you, I'm not even sure a partial thickness cuff tear is a problem, but this study looked at the use of intratendinous injection of MSCs and found MRI resolution on the bursal-sided tears when they were injected under ultrasound. Another possibility, and this is something that you should keep your eyes on, is taking the bursa. This is a device that we developed with Arthrex called the GraftNet. It's a device that's placed between the shaver and your suction that can collect tissue. We use it to collect cartilage and bone graft during ACL reconstruction, but we also use it to collect bursa. And there's a suggestion that bursa may have a pro-inflammatory effect, maybe provide growth factors to enhance rotator cuff healing, and we can place it back at the site of repair after rotator cuff repair is performed. Another concept is potentially augmenting the enthesis. I told you we have such a difficult job reestablishing the fibrocartilage transition zone between tendon and bone. So there's some good work that has looked at the presence of demineralized bone matrix at the level of the tendon and bone. And this is of interest, and it's cost effective. It might improve the histology and the biomechanics of rotator cuff repairs. So in conclusion, rotator cuff tears are associated with poor tendon biology. They are largely degenerative in nature. When you and I repair these, we typically get scar incontinuity. It has poor material properties. And I think the best place that we can achieve advances is to improve our structural properties. I would say the growth factors are likely not enough and likely need pluripotential cells that are signaled for and licensed to recapitulate the enthesis. And there's accumulating evidence in favor of PRP and bone marrow concentrate. But in the end, I think we're going to need cells, we're going to need signals, and we're going to need a scaffold to improve the durability of our rotator cuff repairs. Thank you very much for your attention, and that is my last talk, and we can take questions.
Yeah.
Roshan,
Yeah.
I must recommend this book of biological reconstruction written by Brian, and I remember the autograph that he gave in the center of this. Thank you, Brian. I treasure it.
Thank you. I remember writing it.
Yeah. Any question to Dr. Brian before we go on to panel discussion on case base? Anybody? Sanjay, Dr. Antao, Samir.
I had a question which was related.
Yes, Nagaraj, please.
If I can ask a question related to his first talk, actually, in
Yes,
terms
no
of,
problem. No problem.
in terms of analyzing which are the tears which are likely to progress. So you would agree, Dr. Brian, that the tears which involve the anterior cable, when it is ripped off from the anterior cable, are known to retract very fast, and then you would land up with an irreparable tear-like scenario. So if you have a patient who is in their 50s, who are not so symptomatic, are there these exceptional cases where you would be forthcoming and telling the patient that you need to get this surgery, and any tips on catching those cases?
Well, I sense you're uncomfortable with my algorithm. I could be wrong, and that's okay, because it is a paradigm shift. Because you think, neglecting these things seems like a bad idea. But to your point, the key factor there's two key factors. One is the 50-year-old age. If a patient comes in and is clinically symptomatic, I have a low threshold to repair those for the reasons you just said. But if the patient said, "Doctor, can I avoid surgery and avoid problems down the road? Is it possible?" The honest answer is yes. So those who wish to avoid surgery for whatever reasons, I give them the opportunity, but I do cite the possibility of progression to something that could be more challenging downstream. But you know that even if you repair that tear with the best biomechanical construct, even if you add something like I just showed you, 20 to 25% of them at 1 year will have a re-tear. So how do you look a patient in the eye and say that I'm going to solve your problem when 25% of the time, anatomically, they're not even healed at 1 year? So I think it's a very important narrative, and there's more than one right answer. I do not fault anyone for doing surgery in the patient you described. I'll tell you what I would fault. It's like healthcare economics. It's like COVID, testing asymptomatic people. We need it. It's important information. all the surveillance that we could possibly do. If I brought 1,000 people who were asymptomatic in the office and did an ultrasound on them to see if they have a tear, I'm not so sure I'd be recommending repairing all those people. The only reason that patient's in your office is he or she is symptomatic. And I would argue that it's very difficult sometimes to ascertain the difference between an acute traumatic tear and a chronic pre-existing tear. Acute traumatic tears in 50-year-olds, I repair all of them when they want to be repaired. But those who come in with chronic tears, which are most of them, by the way, most of them are not acute and traumatic. Most of them are chronic. I have this hard discussion, and I realize this doesn't sit well with every person, but my experience in the literature at least supports having the discussion and consensual decision-making with the patient.
Thank you. Thank you.
Those
yes.
tests invariably
Yes.
get better when you acute traumatic tests compared to the chronic ones. Brian, one question here. When we inject the MSCs, they are there for some time. What maintains the supply to the cells?
What main things do the cells provide?
Yeah, no, what maintenance, how they maintain the cell, the growth or cell factors, growth factors, what is the...
That's the challenge, is that we're just in, what I do is I dry the field and then I inject the cells beneath it. And and I know that that's a little bit of wishful thinking to say that they're staying there in any meaningful length of time. And the ideal thing would be to follow the time course of healing with these cells, which is over weeks and months, but that's not happening. So we're not using a scaffold routinely or a carrier. I think, though, that as I pointed out, if you look at the animal models, we probably need to be doing a better job. And just injecting a liquid of MSCs is not doing a good enough job. We need to provide cells, growth factors, and a scaffold. And all of them probably matter. I can tell you the cells probably do provide growth factors. They're not likely staying there as long as we'd like them to. But we seem to be getting some advantage, at least the way we're looking at it right now. But I'm not ready to ubiquitously recommend using them given the economic aspects. I still think you need a really good operation for starters. And whether or not this is going to make a material difference, I'm not ready to say.
Brian, the problem with the degenerative rotator cuff tear is the vascularity of the distal supraspinatus. And then when we consider the vascularity, it is a completely avascular zone of supraspinatus tendon, which may not be amenable to the healing. In those situations, any efforts has been given to vascularize that part, you can get a better because the mesenchymal stem cells and the bone marrow stem cells may not de-differentiate into the similar tendon tissue. It may differentiate into fibrous tissue.
I don't think those cells are differentiating into anything, quite frankly, at least the ones we're adding. I think what's happening is it's providing growth factors to do our best to provide revascularization. So the cells themselves are unimportant. It's what they provide that's possibly important. I think rather than thinking of a tendon growing into bone, I often think of it as bone growing into tendon. And I think we probably need to be paying attention to what's going on in the bone as much as the tendon, because you're right, it's a very dysvascular phenomenon. Tendons inherently are very dysvascular. So when you look at the tendon bone interface transition, it's really fibrocartilage that gets mineralized and the blood supply is diminutive. So something has to redeploy the proper biologic factors to recreate Sharpie's fibers, fibrocartilage, and mineralization. And it's a very dystrophic phenomenon. There's lots of type 10 collagen. The tendon itself is very poor biology, like you're alluding to. Not just blood supply. Blood supply is a very small part of the story. It's just diseased, really poor quality tissue. And that's why I think looking at some type of scaffold that can permanently augment the tendon may make the most sense. Think about the hem of your pants. If you have your pants shortened, the tailor folds it back on itself. Or sometimes they even add a ring of some fabric to reinforce it so it doesn't break down. Mentally, I'm more tuned into that than I am on blood supply, because inherently tendons have poor blood supply even when they're healthy. We have to do something that starts at time equals 0 to do a good job, but that reinforces the ultimate construct because the biology is just so poor. Not only does it not hold suture well, let's assume we can overcome that phenomenon by a great mechanical repair. It just doesn't heal like you're alluding to. It heals with fibrous tissue. And until we get some permanent conformational change in the tendon bone interface, we are still going to fail at best 25% of the time.
If there is no question, I think we should go ahead with the case discussion, Brian. You can show the cases, and
you tell
I'll
me
request Dr. Abhay Narvekar. Can you hear me? Dr. Antao, Nicholas Antao, Samir, Nagaraj, Dr. Jiten Maheshwari, and Dr. Ranajit Panigrahi. Please have a discussion on these cases.
So I have Nicholas, I have Jiten, and who else?
Dr. Abhay Narvekar. He's a senior shoulder surgeon from Mumbai.
What's your first name? Forgive me. I'd like to be able to, you know what? I see the names here. I got Dr. You'll have to forgive me if I mispronounce any names. Forgive me. But I've got Nick, Dr.
No problem. You can go ahead.
Mashawi, Samir, Nagraj, right?
Yes.
Okay, thank you. Okay, I want to see where I want to start because I've covered some of this. Okay, good. So this is a 34-year-old male who has a history of left shoulder.
You need to share the screen.
Sorry. There you go.
Yeah.
Okay. This is a 34-year-old male who has a history of left shoulder pain and had an injection with no relief. He has 6 months of pain, atraumatic onset. He had non-surgical treatment with minimal relief. He wants to sleep and return to tennis, but he cannot, and he cannot get an MRI. He has preserved range of motion and strength, normal scapular function, no AC or biceps findings. He's tender over his greater tuberosity, and he has pain with passive overhead positioning. Nick, tell me about his X-ray and what this finding is, and how you differentiate calcific tendonitis from traditional calcification seen with rotator cuff tears.
The calcification, traditional calcification is just looks always, there's a gap between the bone and the calcification. Always there's a loosened area. Whereas the calcification, the tendinous setting is a little different, is more diffuse, and is not pronounced as the regular calcification.
Yeah, that's exactly right. Okay, so does someone want to? So I don't again because the names are not showing up. They were before. So I know Dr. Maheshwari.
Yeah. So you can see there is a calcification there, and that surely is the cause of pain. And in my practice, I would just do ultrasound to confirm, and maybe give a cortisone injection. I don't give it ultrasound guided, but just a couple of injections to reduce synovitis. And this may dissolve, may not dissolve, and eventually maybe a arthroscopic removal if he doesn't respond to cortisone injection at least 2 times.
Okay, Samir?
Yeah, in such patients, usually we do arthroscopy in these patients and see the nature of the calcification, how it is, like whether it's widespread or it's localized to that region, and we would like to debride that.
Okay, thank you. Okay, who has not spoken yet?
So I'd just like to add one perspective, Nagraj Shetty here. I think for a lesion which is so small, the calcium deposition is so small, and the patient has already had a steroid injection, I would subject him to an ultrasound evaluation, where I would keep the option of barbotage, the needling and the barbotage, where the calcium is dissolved, and then give a steroid shot in the same setting. For a small lesion, I keep the option of barbotage.
Does anyone else have experience with barbotage?
Yeah, I think I have a different way here. I will be very conservative for this patient. He's just a 34-year-old male. He wants to sleep. Yes, we can do the ultrasound guided injection, and eventually he'll get pain relief. I don't want to jump on directly on the surgery. Before that, I'd like to investigate this patient in the form of MRI and CT scan to analyze the amount of calcific tendinitis and calcification in the supraspinatus tendon and which zone. Basically, Sugaya has described these zones. If it is more anterior, then it might require some of the surgical management because eventually it will lead to early tears. But if it's a posterior, more vascular area, they eventually heal.
So great comments. I'll tell you that I personally don't have any experience with barbotage, but I will do an ultrasound injection. And I'll try to get the needle in there sometimes, but we haven't done a lot of that. But I did give him a sarcoma injection, did give physical therapy. Nothing has improved, although we had temporary relief with the injection. So he did come to surgery.
Ben, can I ask why this MRI was not possible in this case?
He had a pacemaker, and it was just a hassle. And I knew what he had. I was comfortable with my diagnosis without an MRI, but he had a pacemaker. He could get an MRI, but you have to demagnetize it, and it was just not worth it to me. So I want to ask you some, if these patients come to surgery, Nick, came to surgery, what do you do to find it? Because you get in there, and this is the intra-articular view. Do you have any tricks on what you can do to actually find the area of calcification?
Yeah, Dr. Brian, usually when we see for the calcific tendinitis and arthroscopic view, we see it on the intra-articular as well as on the subacromial side.
Yeah.
On intra-articular side, if you'll see, we see some bulge if it is present. And if it's on the bursal side, usually we see some of the whitish structures overlying the bursal tissue also sometimes. Or there is a bulge like as if it is within the interstitium or within the tissue. It is there. We need to do a needling for that. We need to find that after needling that sprinkles everywhere. After that, you might create a bursal tear also sometimes, or you might make a full thickness tear also, which needs to be repaired.
All right, those are some really good comments. I found that this is a very inflammatory process, which is why they hurt. Oftentimes you see this vascularization phenomenon on the undersurface of the cuff, just because this is just a very hostile situation. It's interesting, sometimes patients present where they go to bed at one night and they wake up in the middle of the night and they feel like someone just, they got hit by a truck. It can be extraordinarily painful for people. And I will say that when you have these and they do come to surgery, part of maybe why I like doing these is because they're so much fun. When you get to do this in the operating room, it's one of the most gratifying things you can do, It's like decompressing an abscess. And I think just doing that, they often will feel better. In this situation, I had this calcification here, and this is what he was left with. And I guess I'd like to ask what someone would do next in terms of, can I leave this alone or do I have to repair it? And what do we know about that?
Definitely you have to repair it. It's on the bursal side. Usually.
You think you'd have to repair it?
Yeah, bursal tear, yes, has to be.
Can I come in?
Yes, please go ahead.
Yeah, so that is one question I wanted to ask. If you look at the X-ray, the calcification is much above where the tendon is. So I would presume that this tendon itself is normal, or only the superficial part of the tendon has this calcification, which means at worst, I can call it a partial tear. And if I remove the calcium, it will remain something like 25%. Sorry?
Yeah. Dr. Marashali, I would agree with you. I think that it's exactly as you just said. And I don't think there's any literature that tells us what we need to do, quite frankly. I think the problem was the calcium. And I think getting it out to any degree, because if you look in the literature about the degree of calcium removal, it doesn't always correlate with clinical outcome in every study. But I still fixed him, okay? And but I treated him like I never fixed him. These have a high propensity to potentially get stiff because they're so inflammatory. So I fixed him because it was easy, but I treated him as if I didn't fix him in terms of his rehab, and I got him going very quickly. But I think there's nothing that tells us what we need to do, whether we fix that or not, in that scenario that you just described, which is not on the tendon, but more upstream, partial thickness. I think the operation is decompressing it and getting the calcium. You don't even have to get all of it out of there, but opening it up is what makes them better, because they feel better the next day. They come to your office and they already feel better. That has nothing to do with the rotator cuff healing, obviously. So they're just some comments. I think it's a—
Brian, did you complete the tear and then repaired, or what did you do?
No, I just took the top layer. I grabbed this tissue here and brought it over here with a single double loaded anchor and just brought this over. I mean, I could have done a side to side. I could have done nothing, and I think the patient would have done fine, quite frankly.
Okay.
That's my opinion.
Competition, so I should be doing this and get put
There's
And
yeah, go ahead.
can you, sometimes you see this as a toothpaste. When you go through this, it just comes out. And
Yeah.
sometimes you see it as a hard structure, like the other slide that you have. How do you radiologically distinguish the two things?
Well, I think that was one of the first questions I asked, if I think I'm understanding your question. I've rarely seen this as a hard structure. If it is, then it might be the traditional calcifications, which are in continuity with the bone, which are associated with rotator cuff pathology and not calcific tendonitis. The ones that I've operated, I cannot recall anything other than what I show you in this video, okay? To be quite frank. If the bone, and I wish I should get one for comparison, but if this calcification is irregular and in association with no gap, like was pointed out so astutely, and it was attached to the bone here, that is more commonly associated with rotator cuff pathology. And indeed, you will see a piece of bone, and that's not the cause of their pain. That's a sign of underlying rotator cuff pathology in my experience. I don't know if I answered your question, but that's how I interpreted it. I almost always see this. Okay, let's move on to a different one. Listen to this history. Let me see here, hang on. Oh, I get no sound.
No, I don't.
When did your shoulder, how old are you?
56 years old.
Are you right-handed?
I am.
Do you have diabetes or thyroid problems?
No, I don't.
When did your shoulder problems begin?
6 months ago.
Was there any event, or was it just insidious over time?
Over time.
Since your shoulder problems began, you've had how many months of physical therapy?
I had about 24 sessions.
Any relief of your pain or stiffness?
No.
You've had one injection.
I did.
What was the response to the injection?
5 days, no pain.
Good. What is it about your shoulder that you would like to see improve?
No pain and motion.
And is night pain and sleeping difficult?
It is.
Thank you. Okay, both arms up over your head. Bring your arm down, arm like this. Roll out to the outside. Can you reach up behind your back at all with your right arm?
No.
No. Difficult?
Yes.
Okay, bring your arm back like this. Make it strong, don't let me push. Okay. Thank you.
Okay. So I love this case. Oh, no. I love this case because it's such a diagnostic dilemma. Nagraj, what's her diagnosis?
So the first thing that comes to mind obviously is that the patient is having some sort of a rotator cuff pathology, but your examination doesn't show the passive range of motion. So I'll be very careful in confirming whether she has any stiffness component, because pain could be because of the cuff pathology. In addition to that, there could be the periarthritis component also. So the passive
there was an obvious lag in your examination, shoulder lag in right shoulder as left.
I'm not sure she has a lag. I think she has active and
both
passive
arms up over your
motion.
head.
So the difficulty in reaching the back is not only because of pain, but we have to rule out whether she's stiff also.
Yeah, I mean, look at, I can tell you that I didn't show you her passive external rotation, but it equaled her active external rotation. She does not have a lag.
But with that kind of a small tear, she cannot have so much restriction of movement if there is no frozen shoulder.
I agree. So what's her primary diagnosis?
No, but there is something else.
My diagnosis is frozen shoulder.
Yeah, I agree. And so what do you tell the patient? Dr. Narvekar, is it Abhay? Is he on one of you on the panel?
I think the thing is that you probably do. Yeah.
Sorry.
See,
Hi,
if
Dr.
in case, if
Yes, go ahead, Dr.
I can't
Narvekar.
hear anything yet. There's a problem. Hello.
Yes.
Hello.
Yeah, we can hear you.
I can hear you.
Can you hear me?
Yes,
So
yes.
this is basically a periarthritis over a probably started off with an impingement which has progressed to a tear, and her primary problem now is probably stiffness, and I would probably give her a little bit more supervised program in order to get her range back. And if I'm able to do that, and then I will probably recommend surgery for the repair of that cuff, making it very clear to her that after the repair, the stiffness and the whole process to reverse is probably going to take a long time, unlike other rotator cuff repairs.
Yeah, this is an important case. I think everyone on the panel gets it. But I think in the community, sometimes it gets missed. And the discussion is that treating the adhesive capsulitis, required treatment is diametrically opposed to the treatment of a rotator cuff tear. If you get it wrong, you end up with a painful stiff shoulder, just like you started. So she had all the classic findings, and at least intra-articularly looked okay. And I want to ask you what you would do and how you decide. In this patient, she had a small rotator cuff tear, less than 1 centimeter. Okay. So I want to know what you would do to the stiffness and what you would do for the rotator cuff. So someone want to, let's see, Jiten, is it?
Yeah.
Forgive me.
Yeah. So at the moment, I think I would just concentrate on gaining the range. And if enough conservative has been tried, which I suppose has been tried in this case, I would go in with a arthroscopic release. I wouldn't touch the rotator cuff. Maybe I'll do a subacromial decompression also along with it. It's a small tear. I don't think that is contributing to anything. I can just ignore the tear. I can take care of the stiffness part.
What's the downside of repairing the rotator cuff?
You just don't serve any purpose. It doesn't serve. If you're repairing the rotator cuff, would you like to give her a rest? If you do, it will lead to stiffness again.
What if you repair the rotator cuff and then ignore the fact that you repaired it and treat her like a stiff shoulder?
Yeah, I can do that. I can repair it.
That's precisely what you do. Yeah.
Okay.
Other schools of thought.
What I usually do is when I run these
schools of thought where you do a release, extra capsular release, anterior inner capsular release, and do repair and then aggressively rehabilitate.
Yeah. Whenever I do case studies, I usually ask questions to hear the answer I really want. Doesn't mean we have to agree. So that's exactly what I did. I did an anterior and posterior release down to the 6 o'clock position. I used a Bankart elevator, and then I performed a manipulation. And then I just did a very simple, she had a tiny tear. It was a nothing that I could find. Intra-articular was intact. And then I treated her post-operatively like a stiff shoulder. So that's what was done.
But did you repair the tear?
Yes.
Okay.
There is enough literature to support now that simultaneous capsular release along with rotator cuff tear can be done.
Not in my opinion. If you guys know anything, let me know. If it's a very, let me just say this. If it's a very big tear, I will not repair it. That happens. You can get fooled sometimes. Sometimes you see them in the office, they don't come to surgery till 3 months later, and they weren't stiff in the office, and then they come and you operate on them and they're stiff. And in everyone's mind, they thought she was getting a repair, and you go to the operating room and it's a stiff shoulder with a huge tear. I don't fix those. I do exactly only the half the operation, and most of those never come back to reason.
Can I ask a question?
Yeah, of course.
Yeah. So, how common is significant stiffness with moderate to large size tears? In my experience, these two don't coexist. If it is a medium to large tear, the shoulder is not stiff. It's stiff only with small tears.
I agree with you. And I'll even reinforce that further. When you fix a small tear, they have a higher propensity to get stiff.
Right.
Yes.
Right.
Yeah.
They get a lot of headache. You think it's a small tear, you fixed it, but they actually become very messy in terms of getting the movement back and things like that.
Yeah, no, I agree. These are really important teaching points for the audience.
Yeah.
30 is 4 months.
Can't hear though.
Yeah, you can't hear it as well, but I put the writing on the bottom.
That's okay.
Can I add something?
Yes, Nagaraj.
So Dr. Cole, do you think an intra-articular steroid, especially an ultrasound guided intra-articular steroid, which makes sure your drug is reaching all the inflamed periarthritic tissue which is there intra-articularly, which we are basically releasing, is going to give as good results and a lesser stormy course, which is typically seen in these patients? There's a pretty much of a stormy course post-op. Do you think?
So what I do is preoperatively, as part of my non-surgical treatment, I always do an intra-articular injection or ultrasound guidance, okay? That I feel very strongly, because that helps even temporarily get rid of the pain so they can tolerate physical therapy. But when they come to surgery, it's because they failed non-surgical treatment, have had no progression. Post-operatively, I put them on a Medrol dose pack, but I don't give them a steroid. But there's a great question. I think we should stop. It's 2 hours on the button. Maybe we can take any questions if you guys are okay with it.
So yes, Brian. Is there any questions to Dr. Brian?
Brian, can I ask one basic question? Hello.
Yes, go ahead. Yes.
Yeah. So my question is, sometimes I tend to feel when a patient has a small tear, pain is the main.
I lost you. So try again, and everyone else mute their phone, please.
Jiten, can you? Yeah, now we can hear you, Jiten. Go ahead.
Yeah. So my question is, if you have a small tear, say 1.5 centimeter, where patient has main symptom is pain. Now, in his pain,
your voice is breaking, Jiten. We can't hear you.
Ken, I'm sorry. You get it the first part of your question, and then you get static, and I can't hear you. I apologize.
Okay. Is it okay now?
Yeah, it's okay now.
It starts out fine, and then it goes bad. Try it again.
Maybe somebody else can talk. No problem.
Yes. Ranjit, Jayaprasad, you had some question to Dr. before we end?
Yeah. Brain Cole, this is mainly in our practice, this patient like partial tears or small cuff tears, initially like partial tears basically, and some tears they will have a lot of pain. So there, then even large tears also they will have a full function, but main problem is the pain. So apart from the steroid, so what are the other things you will make to have in your treatment, non-surgical treatment for these patients?
Other than non-steroidal anti-inflammatories, which I will use. In fact, I use ibuprofen, 800 milligrams 3 times a day. I don't use narcotics ever. I do use ibuprofen, which I think is a great pain reliever. In fact, even for surgical pain. It's a lot of counseling, I think. And then, so the intra-articular injection, Medrol dose pack, and oral anti-inflammatories. And when all that fails, surgery. It's a pain. You're right. The pain is a big part of this one. And I think it's why we have worse outcomes, because it's a pain condition.
Yeah. Any other question before we end? It's already 2 hours now. Samir, last question.
Do you believe in doing? Do you believe in doing a supras?
Just a minute, Dr. Antao. Samir is asking question. Samir, Samir, just go ahead. Samir, yes.
Yeah, Dr. Brand, do you believe in doing a suprascapular nerve release in your massive rotator cuff tears?
I think intuitively it makes sense, but I don't do it. That's the honest answer. It's just more time. Don't know if it makes a difference. I don't think JP Warner study shows that they're better, but it shows that the nerve is involved. And it probably doesn't hurt if you're good at the operation, but I don't do it routinely. I do the operation for a different indication, either spinal glut or supraclavicular notch, but not in a chronic rotator cuff tear. I do not. That's a bit of a chicken and the egg concept. Intuitively, not a bad idea, but I don't do it.
Dr. Antao,
have you ever regretted not doing it?
Sorry, Tony?
Have you ever regretted not doing it?
I'll never know. You don't know what you don't see. I'll never know.
Okay. So I think we all must should thank Dr. Brian for his 2-hour session on rotator cuff. It was a wonderful all insight of rotator cuff, start from decision making to massive to orthobiologics uses in rotator cuff tear management, as well as a nice panel discussion of 2 cases which are very common in our clinical practice. Thank you very much, Brian.
So,
it was
more so the clinical examination, pre and post-op. That is the most important thing.
Yeah, more so it was a clinical examination.
A lot of lessons for us to learn. Thank you, Brian, being so clinical and coming over, spending your time for this academy and educate us.
And I will guarantee you many of our Indian colleagues will attend the Chicago meeting, provided COVID situation is controlled. And once the COVID is controlled, at least you can see this 10 in frame. They will at least try to attend.
We would all be grateful, and we
yes, surely. That's our responsibility to make ANA Chicago meeting more successful.
And we'll be seeing you back again for the Arthroscopy Academy.
Yeah, in Mumbai. Yeah, he has promised me he's going to come to Mumbai once. Yeah. Thanks, Brian. Thanks.
Thank you, Brian.
Thank you. Bye. Good night.
Brian, one last question. How do you always remain young like this?
How do I what?
How are you?